Now, as we proceed to the next part of the day, the International Speaker Program, I'd like to introduce you all to the faculty for today. Dr. Philip Rajan Devesahayam, he is an adjunct professor at the Taylor's University, Malaysia. Sir has specialized training in otology, cochlear implant and endoscopic ear surgery. He has many publications in various reputed journals. Sir has also received many awards in local and international level. Dr. Anita Bhandari, ma'am. Ma'am is a well-known name in the field of vertigo, and we are very obliged that ma'am is from our own city, Jaipur. I welcome you both, ma'am and sir, and we are looking forward for the next event. I also welcome Dr. V.K. Kapoor, sir, Vice Chancellor, Dr. N.D. Soni, sir, Principal, Mahatma Gandhi Medical College, Dr. G.N. Saxena, sir, and Dr. Tarun Ocha, sir. We welcome you, sir. As we wait for our chairman, sir, we start with the talk. I request Dr. Philip Rajan Devesahayam, sir, to kindly come up for his lecture. Students, kindly be seated. This is surely going to be an amazing learning experience for you all.
It gives me a great pleasure to be speaking in front of all of you all. I'm really honored for this invitation to be part of this wonderful event. The speakers just now, you all spoke very well, excellent talks. I would like to especially thank the Mahatma Gandhi University faculty, Dr. Ashal Lati, Dr. V.K. Kapoor, Dr. N.D. Soni, and Dr. Tarun Ocha, the ENT. Thank you very much. I would like to especially express my gratitude to Mr. Bhandari, Dr. Anita Bhandari, and the Neuro Equilibrium team for also facilitating my presence here today. Thank you very much. So what we have here on the slide here is the first time I met Dr. Anita, and rightly, as the MC mentioned, she is your Vertigo champion. So I first met her last year during this Vertigo Masterclass in Ho Chi Minh City, Vietnam, 2023, and that's Dr. Anita, that's me. And in the center is Dr. Professor Michael Spruck from Munich, Germany. So that's how we developed our professional relationship, and I'm here today to share with you a little bit on what I know about Vertigo. So I'm going to give you two lectures in one. One is a little bit on Vertigo, and the other is on geography. Okay? So that is Malaysia. So I am from Malaysia, but I am of Indian origin. So I'm just like you all, just that I was born in Malaysia and raised up there, but genetically Indian. So Malaysia is divided into two parts. It's got a east and a west, and it's divided by this South China Sea. So I come from this place called Ipoh. So probably you all may not have heard of Ipoh. Anybody has heard of Ipoh? Hands up? No, none of you all have heard of Ipoh. So basically Ipoh is like Jaipur. It is a landlocked town between Penang, I'm sure some of you all would have heard of Penang, and Kuala Lumpur. So those are the more famous cities in Ipoh. So I come from in Malaysia. So Kuala Lumpur, Penang, most people know. Ipoh is in between Kuala Lumpur and Penang. So So this is the hospital I work in. I work in a government hospital. It's a 2,000-bed hospital. I do a little bit of private practice. So the lovely girl on your right, anybody knows who that is? Michelle Yeoh. Okay, so I heard Michelle Yeoh. So those of you all who watch American movies, Michelle Yeoh is from Ipoh. Okay? So if you ask me what's famous about Ipoh, I would say Michelle Yeoh. Okay? So if you're watching Netflix, I think now, Brother's Son or something, there's a series going on where she acts. She's also a born girl. So she is from Ipoh. How to fight insomnia? So what is this slide doing here? What has it got to do with Vertigo? So the problem is, when we talk about Vertigo, most of the time what happens is, people start falling asleep. So if you have a problem going to sleep, record this talk, okay, and tonight play the talk. Okay? Maybe it will help you sleep, right? So the idea is not to confuse you, but after these sessions, you must have a better understanding of Vertigo. And my topic for today is the eyes, window to the vestibular system. So before I go on, this is a book that was published by Jaipur Brothers more than 10 years back. So some of the material that I'm going to use in this lecture is from that book. Some are mine and some is from Professor Prabhakaran. So if any of you all are recording this, please don't viral it anywhere. You can use it for your own purpose, but please don't viral it. If not, I will get into trouble. Alright, so what is a vestibular disorder? It is a disease or impairment affecting the vestibular system. And rightly, as you mentioned earlier, the vestibular system is divided into a peripheral and central system. So peripheral is the inner ear and the vestibular nerve. Central are the central connections in the brain, which involves the big brain, the brainstem, cerebellum and cerebrum. So peripheral vestibular disorders, as one of our colleagues mentioned just now, there are a list of disorders, but the most common are the top three. Benign paroxysmal positional vertigo, which Dr. Anita will explain further. She's an expert in the field. And then you get episodic vertigo, depending on the position that you are in. Then there's Meniere's disease, which is a triad of vertigo, hearing loss and tinnitus. And those episodes last for a duration not longer than 24 hours. And the other common cause is vestibular neuritis, that is severe vertigo lasting for 2 to 3 weeks. And this is important because this is where patients present acute vertigo with severe vomiting. We need to rule out a stroke. Then there are other conditions like third window syndromes, which are like superior canal lesions, ototoxicity, trauma. And then our colleague, our general medical colleague, also talked about medical causes, strokes, tumors, multiple sclerosis. These are the things we do not want to miss. And we have migraine. Migraine is something that is increasing in the population. We are increasingly diagnosing it. And it is something you need to be aware of because sometimes we dismiss migraine as not a disease. Okay, so be careful, be aware of this condition. To diagnose these patients, you can actually make their life much more comfortable. Symptoms. What are the symptoms of a vestibular disorder? When there's impairment of the vestibular system, usually it results in hypofunction. Hypofunction means there is a reduction of nervous input from one side. So because of that asymmetrical input, the brain, our cerebrum, cortex, perceives that as movement. And that's how we sense vertigo or vertigo, depends on how you want to pronounce it. So we feel that there's a sensation of movement. When in actual fact, our surrounding is not moving. So that is why sometimes vertigo is defined as a hallucination of movement. So, and the other symptom is, like our pharmacologist colleague mentioned just now, it's vomiting because the emetic pathways are involved. So remember these two symptoms, nausea, vomiting, and of course vertigo, a sense of movement. Then what are the signs? So the two primary reflexes involved are the vestibular ocular reflex and the vestibular spinal reflex. So the vestibular ocular reflex helps to keep our eyes focused. So as I move now, I'm able to keep my eyes focused on all of you. Okay? So I don't fall. Okay? My eyes are not moving up and down. And it's because of this reflex, which is so fast, so effective, so efficient. And if you have a problem with this reflex, it results in nystagmus. And that is what I'm just going to share with you all shortly. And the other reflex that is involved is the vestibular spinal reflex, which helps maintain posture, and this prevents falls. So again, this is involved in balance. And if we want to look at that reflex, we look at a patient's balance. So the test that we do, like the Rombergs, Hampton-Burgers, are actually to assess this reflex. Now, when we examine a patient, there is something called neuro-otologic examination, and those are a series of examination steps, okay, to look for disorders of this vestibular system. Okay. So there are a series of tests like the head impulse test, oscillopsia testing, head shake nystagmus, and the most important of which is spontaneous nystagmus. So when you go back today, there are two important tests that you need to be able to know how to do. One is spontaneous nystagmus, and the second is the Dick-Sulfide test, because BPPV is the most common cause of vertigo. So the word nystagmus comes from, it's Greek in origin, and basically it talks about nodding or dozing off. So what happens if you are sleeping? Your head goes down and suddenly you wake up. Okay? So there's a slow phase and a fast phase. Okay? So that's how the word nystagmus came to be used for these eye signs. So how do we do it? It's a simple test. Place an object in front of the patient or person and move the object. And like our colleague rightly mentioned, there's a physiological endpoint nystagmus. So don't move the object too far laterally. If not, you will get a physiological nystagmus and you will misinterpret your findings. Okay, so now I'm going to show you all some videos. So this is a common biphasic or jerk nystagmus. So there is a fast component, okay, and there is a slow component. So the nystagmus corresponds to the fast phase, okay, and it beats away from the site of the lesion. So if you have a left-leading nystagmus, it suggests that the etiology is on the right side. Okay, so this is another video. This is taken from YouTube. So you see there is a horizontal biphasic nystagmus, okay, and the nystagmus beats the patient's left. So where do you think the lesion is? The fast phase is to the left, the lesion is on the, it beats to the left, lesion on the right. Very easy, okay? Very good. So now there's another type of nystagmus. Now this is called a pendular nystagmus, where the velocity is equal both sides, to the left and to the right. It's like the pendulum of the clock. Okay. So when you see this type of nystagmus, it's either congenital or it could be due to a central cause. Okay, that's EPO. Okay, just to break your attention a little bit. Okay. So EPO is a bit like Jaipur. It's a landlocked city. It's surrounded by two mountain ranges, and you have these limestone hills. Okay. There are around 18 limestone hills, which are among the oldest in the world. And on top of these limestone hills, some of these limestone hills have sort of little lakes. Okay. Unfortunately, a lot of these limestone hills have been quarried extensively to make cement and also get marble from these hills. But that is one of the unique features of Ipoh. Okay, so nystagmus of peripheral vestibular disorder, these are the four features. One, it always beats in one direction. It's horizontal. Okay? So if you see something that changes direction, it is not peripheral. So it beats away from the site of the lesion. It's conjugate. Conjugate comes from the word conjugal, means a couple. Okay? So a couple who are in sync with one another should move together. Okay? So if there's this conjugate, there is some problem, something serious is going on, and that suggests a central problem. Okay? And finally, you have raised Alexander's law. So this, if you look at this video, where is the nystagmus leading towards? Patient's left, lesion on the right. Very easy. So it's conjugate movement, both move together. It's horizontal, so it fulfills the requirement of a peripheral vestibular disorder. Now, if you see something like this, vertical. So vertical means you are thinking of a central vestibular disorder. So this patient actually had a very rare anterior canal BPPV. So, but if you see someone with a vertical nystagmus, the first thought that should come to your mind is whether this patient is having a central disorder. Next is gaze-evoked nystagmus. So you will come across this term when you read medical books. What does gaze-evoked means? Gaze-evoked is basically when the patient looks at the extremes of gaze, it beats towards that direction. So it's basically a direction-changing nystagmus. So the moment you see a nystagmus which changes direction, again we are thinking of a central vestibular disorder. Okay, like I mentioned to you, this is the video that I showed you earlier. Okay. Conjugate means both sides will move together, and that is a feature of a peripheral vestibular disorder. And this is disconjugate. So there's no harmony between the left eye and the right eye, and this suggests a more serious problem, something affecting the central vestibular system. So if you see a patient like this, she has difficulty keeping her eyes open. So this is one of the disadvantages when you look at the patient directly. If you have a nice video goggles, capture the eye movements, you can sit back in your computer later and look at it, and you can really pick up the signs more easily. But what do you think? Is this central or peripheral? So this is actually central because there's direction changing, there's also a vertical component. Now this is a vertical nystagmus, and it is gaze-evoked. Gaze-evoked can be either horizontal or it can be vertical. Again, if you see something like this, is this central or peripheral? Central. Very good. So what do you see here? Okay. Someone mentioned in the lectures just now about a seesaw nystagmus, right? A seesaw nystagmus. So this is a seesaw nystagmus where you see one going up, the other going down. Okay? A seesaw nystagmus. And again, this is disconjugate movement because they're not moving together. The one is going up, the other is going down. And that you find again in a certain brainstem lesion. So again, this is a central nystagmus. So here you see, what you see is actually a, what type of, so this is another patient. She looks to the left, see the direction of the nystagmus? Left or right? Very good. Straight, there's nothing. So she looks to the right. Where is it eating? It's eating to the right. So this is called gaze-evoked nystagmus. Very simply, just remember it's direction changing. So direction changing nystagmus is central. Very good. So what is this? So this is a tin dredge. Okay? So the Ipoh is also famous for tin mines many years ago. So Jaipur also, I think, a lot of mining activities going along around here. So this is a tin dredge. So it used to dig the sand, okay, and it looks like a boat, okay? And that area is filled with water. So at one time the area around Ipoh was filled with this sort of mining pools. We call it mining pools, okay, because of the tin mining activity there. So finally we talk about Alexander's law. Horizontal nystagmus obeys this law, which says it's always one direction, horizontal, and it beats stronger in the direction of the nystagmus. So this is a patient. Look at the eyes. It is beating to the right. Still beating to the right when she looks straight. When she looks to the other side, it is slower. So this is a third degree nystagmus. Patient with a left-sided vision. So what happens is, after 5 days, after some time, this process of central compensation takes place and the nystagmus is slowly suppressed. So after 5 days, when we look at the eyes, there was hardly any nystagmus except a mild nystagmus when she looked to the direction of the fast pace. Okay? So from a grade 3, it dropped to a grade 1. Which direction is the nystagmus? Leading to the patients? Right. Okay. So where is the lesion? Left. Very good. This patient actually had head trauma. That's why you see the bandage around the forehead. So what do you think is happening here? Is this a central or peripheral vestibular disorder? Sorry for the background voices. So this patient, what does this patient have? This patient does not have nystagmus. It's actually a right lateral rectus palsy. Okay? So, this is a trick question, because if your mind is tuned to nystagmus, so I put this video in. So, in Malaysia, nasopharyngeal carcinoma is common, especially among the Chinese and Malay population. So, I don't think you see it much here, but we see it commonly. And lateral rectus palsy, diplopia, is one of the early signs to pick up nasopharyngeal carcinoma. So, again, this is Ipoh. So just like Jaipur, there are a lot of temples. And that's a Buddhist temple, and that's a Hindu temple. So remember the limestone hills I told you all about? So into these limestone hills, there are a lot of caves. So out of these caves, outside temples are built. So again, Ipoh is famous for caves. Okay, so you may need a device to appreciate the nystagmus better, and one of that is to use a Frenzel's glasses, because it removes optic fixation, and the other thing is it illuminates the vision. So this is
rapidly back and forth.
Head shake
The head is
nystagmus.
pitched down about 30 degrees with the lateral canal, roughly in an horizontal plane. And then we look for the nystagmus induced by the head shaking. And it's a right-leaning nystagmus with a slight torsional component.
Okay, so
Slow phase toward.
So that is a head shake
Rapidly
nystagmus.
back and forth.
So sometimes when you see the patient, compensation has taken place and you do not appreciate the nystagmus, one of the ways to trigger the nystagmus is actually to do this head shake maneuver. So this is a gentleman that I saw in my clinic. Okay. Complained of persistent dizziness. So this is me doing the rhomboids. So he's not very stable. It's difficult to see, with the naked eye to which side he's swaying or to which side he's falling. So we asked him to walk. I think he's falling to the left or to the right? Right. So, we did a head shake nystagmus for him. Go right side again. So ask him to the right, to the left. So there's no. After doing the head shake test, see the nystagmus, a slight nystagmus leading to the left. So lesion is on the right. Very good. So you all were right about your observation earlier. Okay. Okay. So those are spontaneous nystagmus. So now the other group of nystagmus, which Dr. Anita will be elaborating more on, is nystagmus that you induce through movements. So the most common of which is the disc-sulfide, which your colleague demonstrated earlier. Okay, so I'm just going to skip the video. And what you get is a torsional or rotatory nystagmus. And it stops. Okay. So this is a fistula test. Okay. So I just would like you to see this video. When pressure is applied, there is nystagmus. Okay. So this patient had a fistula secondary to a cholesteatoma. Okay. And when you apply pressure, nystagmus is there. Okay. Another way to apply pressure is by using a Seagull speculum and you just press the insufflator. Okay, so I think this is my last video. Can you tell me whether this patient has a central or peripheral disorder? Looking at the nystagmus. Central or peripheral? Very good. If she actually had an artery malformation. Okay, so there's herniation of the brainstem, and she was actually quite well. Okay, but this is what we observed when we saw her. We did an examination of the eyes. Sorry, one last. So what do you think so far? Peripheral. So now what do you think? He's got a facial nerve palsy. Okay? So don't just look at the eyes. You must look at the history, look at other clinical signs, okay? And then you put all the pieces of the puzzle together to come to a diagnosis. So, just because I spoke to you about nystagmus, don't just look at the eyes and try to make the diagnosis. Look at the patient as a whole, do a complete neurological examination. If you see any neurological sign, the first thing you want to rule out is a central cause, a stroke or some tumor or something. Right? So my last slide about EPO. So if you go to Southeast Asia, if you go to Singapore, okay, very often you will see this white coffee. Okay. So this white coffee had its origins from EPO. Okay? And it's the coffee white. It's like an oxymoron, two words that don't gel. Right? How can coffee be white? Right. So why is it called white coffee? Because it's actually roasted in butter, so that's why they call it white coffee. So anyway, this originated from Ipoh, and if you go to Singapore, parts of Southeast Asia, there'll be Old Town white coffee, various restaurants serving white coffee. So now you know where it came from. And another thing you see here, this is Ipoh chicken rice, and these are bean sprouts. Because of those limestone fields I told you all about, the mineral content in the water is different. So it is supposedly one of the best and tastiest bean sprouts that you can find in Malaysia. So Ipoh is very famous for that. And you have this big orange-like fruit, which are pomelos, which is also a specialty of Ipoh. So that's a little bit about Ipoh. But it's nothing like Jaipur. We don't have your palaces, we don't have your forts, we don't have your great food, your rich heritage, your culture. And I must thank all of you very much for having me here today. Thank you.
For this wonderful lecture and a journey to Jaipur. I welcome our chairperson, Dr. Vikas Chandra Swarnkar, who's taken out time from his busy schedule to grace the event with his presence. Dr. Vikas has always been very active in promoting academic events. Also, our founder chairperson, Dr. M.L. Swarnkar, is also always present in all the academic events of the university. But today, as Sir is out of town, so he could not be here with us today. But we know his blessings are always there with us. I now invite Dr. Anita Bhandari ma'am to kindly present her talk on the topic, Recent Advances in Diagnosis and Management of Vertigo.
Good afternoon, everyone, and I'd like to start with a special thanks to Dr. Vikas Swarnkar for arranging this, and especially seeing all the undergraduates present so well to build up the topic. And I wish we had things like this in our undergrad times. It's really, really interesting, a very nice way of involving everyone. Thank you to the Mahatma Gandhi senior faculty, along with Dr. Tarun Ojha and such senior faculties, including my teachers, Dr. G. N. Saxena sir, and all my colleagues here. So today I'd like to talk about BPPV, which is one of the commonest causes of vertigo, and what the patient actually feels is that, again, the colleagues talked about the inner ear structures and the anatomy, and here you can see when after a fall or after certain vestibular disorders, a crystal from the utricle escapes, gets dislodged and gets stuck into one of the semicircular canals. And when the person bends down or turns in bed, because of the movement of that crystal within the canal, there is stimulation of the nerve fibers and dizziness or vertigo occurs. So BPPV is basically a three-dimensional disorder of the inner ear, and treatment of the dislodged crystal which has come into one of the semicircular canals is actually bringing back that crystal to the utricle. But it's not so easy. It's because it's like playing in a three-dimensional maze. You have to know where the crystal is lodged within the semicircular canal, which canal it is, which we find out with the positional test. We know that the final destination of the crystal is the utricle. We have to bring it back there to its rightful place. But we have to decipher what is the best way to do it with various manuals. Now, various publications show these kind of two-dimensional figures, but here you can see how difficult it is to understand the steps by just these kind of instructions. Some groups have also showed these kind of contraptions to help to understand BPPV. But here you can see there is very little anatomical correlation with what is going on. And to help us in this, we have developed the BPPV simulation models to help us with the software tool and understand in 3 dimensions what BPPV and its treatment actually is. So how we developed the simulations was by extracting the 3-dimensional anatomy of the labyrinth from HRCT temporal bones, and then we aligned this labyrinth with the virtual head. This allowed us to establish the 3-dimensional orientation. And then here you can see the labyrinth, which is linked with the head movement, and this yellow crystal which you can see is actually the displaced crystal. And when we take it to the Dix-Hallpike test, which has been described, you can see the movement of the crystal under the effect of gravity. So in this way, it is easier for us to understand what is really going on. We've seen various speakers talk about nystagmus and how during the positional test we need to identify that. So we linked the canals to the eye movement, eye muscles. And so when there is movement of the crystal within the ear, within the canal, so here you can see now movement of the head. The patient is going down, the head going down, and then the crystal moves. And because of that, the eye movement seen here, the torsional upbeat nystagmus. So it helps us understand all dimensions of the BPPV, the findings which we see. Now BPPV can affect all the 3 canals. What our colleague from anatomy had described, the posterior, the horizontal and the anterior. And even within each canal, the crystal can be stuck in various positions. So we have to first understand where is the otolith within that canal, and that is what we do with the nystagmus which we identify. Only according to that will we be able to decide which maneuver works best. So going beyond just one test, doing Dix-Hallpike and you're done, you know that the every will work. Actually things are very different. And I'm very, very happy to share that Mahatma Gandhi Hospital has the complete vertigo setup in which with the VNG and the other various neuro-otological tests, we can actually identify these nystagmus patterns and be able to decipher the underlying etiology. So for a positional test, we must do all 3 canal testing, the supine roll test, the Dix-Hallpike, and last is the deep head hanging for anterior canal. Now, various textbooks have described doing the Dix-Hallpike, and here I look as the first test. So here I'd like to show you why doing the supine roll first before the Dix-Hallpike is actually more important. Now the supine roll test is a simple test in which the patient is taken to the supine position with a pillow under the head and then turned to the right 90 degrees, held there for 30 to 40 seconds, brought back to the center and then turned to the left. So very, very simple to do. So here I'd like to show you with the simulation how a patient who had horizontal canal BPPV, if we do the Dix-Hallpike in this position, we will get a horizontal nystagmus because there is movement which has generated the crystal within the horizontal canal has been dislodged, and this can confound our results. And this is actually a paper which we have published in the clinical practice of neurology along with professors from Harvard and Johns Hopkins Medical School. This is the largest study of acute BPPV, and in which we have seen that the horizontal canal incidence is actually much higher than previously believed. Talking about posterior canal BPPV, which is the most common because of the anatomical structure. It is most dependent in both the upright and the supine position. And when the crystal has to be removed from the canal, it has to take an anti-gravity path. And that is how the maneuvers would work. So these are the various areas where the canal could be stuck. And here I'd like to show you with a simulation that here the green particle is near the crus commune, while the yellow one is in the long arm of the posterior canal. And when we do the Dix-Hallpike test, you can see that both of the crystals have very different trajectories, and hence the anatomy will be the nystagmus generated will be very different. So we can now, with our VNG, also detect the torsion, which is a very important part of the nystagmus understanding. So here in the Dix-Hallpike test for a posterior canal long arm, the torsional upbeat nystagmus is seen, and for this we would do the Epley maneuver. So I just like to show you how we have to take the patient to different positions and wait at each position to allow gravity to move the crystal to the most dependent position. So first in the deep head hanging position, then you turn by 90 degrees to take the crystal further through the canal. And in the next step, we do another 90-degree turn to go to the nose pointing down position to bring the crystal out of the canal and back to the utricle. So here now it's very easy for the clinician or whoever healthcare provider to understand what is going on. Right now the crystal is moved out. So cupulolithiasis is when the crystal is adherent to the cupula. The nystagmus pattern is very similar to what we saw before, but the difference is that it stays for a longer time. If nystagmus is more than 1 minute, we consider it to be cupulolithiasis. And for this, the maneuver which we do is the Simon's maneuver. So in which the patient is taken to the side lying position. And so here you can see the crystal moves through the canal, waiting here again for 30 to 40 seconds. You have to wait till the nystagmus completely subsides or disappears, and then we swing the patient to the other side by 180 degrees, and this allows the crystal to move out. In this paper, in which the group of Professor Obrist, they talked about the determinants of a successful maneuver in the Simon's maneuver. So we also did that, tried it with our simulations. And here by adding an extra 30 degrees to the side-lying position, so you go horizontal and then an extra 30 degrees, we saw with the simulation that the crystal could move further through the canal, crossing the apex of its curvature. And because of this, we could, when we turned to the opposite side, the chance of success was much higher. So this is what we now do for patients of cupulolithiasis or resistant BPPV. And in some patients, you may see this kind of a nystagmus when we do the Dix-Hallpike, a pure downbeat nystagmus. So this should not be confused with central disorders, because this is a BPPV of the crus commune area, and it's treated with the Iacovinno maneuver. So here I'd like to emphasize that BPPV is of many types. In fact, 14 subtypes, depending on which canal is affected, the side, the canal lithiasis, cupulolithiasis. So you cannot just say BPPV in the diagnosis and get away with it. You have to really be able to classify the type, because here you can see in this table for posterior canal from my book, each position will have a very specific characteristic nystagmus pattern and a very specific treatment pattern. So all this is seen in the book. Talking about horizontal canal. So horizontal canal can also be of various types. And just get this, the kind of nystagmus which we see here, when we turn to the right, we get a horizontal nystagmus which beats to the right, and on turning to the left, it beats to the left. But it's important to be able to differentiate which is the side affected. So the side which is stronger, in this case horizontal canal to the left side, was the stronger nystagmus. So here we would start our maneuver from this. So in our publication in the European Journals of Neurology, which we published with professors from Germany, Brazil and Netherlands along with our team in Jaipur, we presented the simulations for horizontal canal and the often performed 270-degree roll, in which you take the patient to the, from the midline to the healthy side and then go for 90-degree sequential turns. We found that this was not sufficient to treat all kinds of horizontal canal BPPV. While the 360-degree roll, the barbecue roll, is actually the most successful and a type of treatment, and it's very simple, just turning the head to the affected side and then going by 90-degree steps sequentially to let the crystal move out of the canal. Here you can see it moving out, and then the patient is taken to the prone position and then another 90 degrees and out. Now, anterior canal BPPV, what Dr. Philip just showed, it is not a very common condition. However, when we identify it, we must treat it properly. So, the Jacobino maneuver was described for crystals present in the anterior canal. In this, the patient is taken to the deep head hanging position, and you wait for about 30 to 40 seconds to let the crystal move through the canal. In the second step, the patient is taken to the chin to chest position. That means the neck is flexed down here, like this. This is the second step. But with the simulations, we saw that this crystal may move out of the anterior canal and enter into the posterior canal, what we call canal switch. In fact, this canal conversion from anterior to posterior is described as a classification of certain anterior canal BPPV. So we presented the modified Jacobino maneuver in our publication, which simplified the maneuver by starting with the deep head hanging step, waiting there, and then omitting the chin to chest position and coming just straight up. So it became very, very simple to do. Head down, come back to the sitting position, but you need to wait here for 30 seconds and then finally bend the neck down. So it was a very simple maneuver to be done. The next step in treatment, to improve the treatment of BPPV, was increasing the accuracy of treatment. So we've described various maneuvers which are actually the gold standard of BPPV treatment, and most patients will not require any medical management. But unfortunately, the ground reality is that only 10% of patients perform these maneuvers, which is actually quite sad. And when we try to investigate why is this happening, why are clinicians reluctant to use the maneuvers, the most common cause was difficulty in remembering which maneuver for which canal. And then even when you know the maneuver, how to do the various steps, what is the order. So to solve this problem, we developed the BPPV guidance system, which has a headband with sensors. And here you can see that in real time, we can track the head position of the patient, and this is matched with the humanoid shown on the screen. And here I'd just like to show it to you how it happens. It's not in hand. So basically with the sensor on the head, you can match the head position, and then the software tells you exactly how to take it to the next position. And then with this we saw that we could decrease the variability of the maneuver. That means without the guidance system we saw so much variability, but when we did it with the guidance system it became much more precise, and there was no need to remember the steps because they were displayed at each step. So thank you so much. This is the final ceremony. We just got a PhD from Netherlands. So thank you so much, and thank you very much.